Okay, thanks for coming today. So we are going to start our next to last live event. And we will have the Warren Court prize winners will be our next event. So that's always fun. And we'll be doing that after Thanksgiving. So following week, we guys have that week off. We didn't take that day. So this is our last talk for a couple of weeks anyway, and I'm super happy to introduce our own Megan Burke. And this is our event in support of Trans Awareness Week. I'm very excited about that, so give Megan a hand and take the stage.
Thanks, everybody. I'm glad to be here. The title of this talk is An Ethics of Gender Affirmation. I'm going to be talking about some of the slides. I'm also going to be reading some of the some stuff to you. What I am going to present is based on a book chapter of a book that I am finishing up writing at the moment. So there's a lot of details that might just be better read than talked about to you. At the heart of what I'm going to share with you, as well as this book in general that I am writing, is just thinking trans experience and thinking with trans experience. And that, of course, relates to what this week is in general, which is Trans Awareness Week, a way to think with and about those who are trans and those who experience transness in some kind of way. So this is, I should say, an affirmative talk about trans existence, but I will be talking about trans antagonisms and anti-trans legislation that exists in the political climate around the world and in the US as well. Before I dive into the actual content, I just want to offer a really preliminary definition of how I am using transgender and trans for short in the context of the talk, as well as the context of my work. And it draws on trans historian Susan Stryker's definition in transgender history, where Stryker defines trans as just the movement across a socially imposed boundary away from an unchosen starting place. So this is actually a important and unique definition. It is a non-identity based definition of trans and transgender. It is in this way a descriptive term that can describe those who identify as transgender, but also those who might not use transgender as an identity category, but nevertheless whose experiences of gender may fall under this description. So when I'm talking about trans and transgender, I'm not necessarily talking about an identity, but a particular kind of experience, and I'm happy to talk more about that relationship to trans and transgender in Q&A if that's of interest to you. So in ethics of gender affirmation, there are kind of two questions that I'm thinking about. Why ought we affirm an individual's self-defined gender? And I take it this isn't what we generally do, and by we, I mean as like a social global practice of gender related to various histories of white supremacy and colonialism, as well as imperialism. And I'm not going to talk about those discrete relationships today, but again, I can do that in Q&A. So why ought we affirm an individual's self-defined gender? And then what is at stake when we refuse doing so? And when we refuse that trans, non-binary, and gender-conforming people are who we say we are? What's going on in that refusal? And I take that refusal to be at the heart of a lot of anti-trans legislation, both in the United States as well as around the world. And then aside from legislation, just in general, trans antagonisms, which emerge in various discourses, including trans exclusionary radical feminism, sometimes often called gender critical feminism. Okay, so here's where I'm going to begin, just to kind of ground this ethics in the world. So in April 2021, the headquarters of Madrid Lesbian, Gay, Bisexual, and Transsexual Collective, or COGAM, located in the city's queer neighborhood Chueca, was vandalized, covered with graffiti of transphobic slurs. Among them were some common taglines of anti-trans discourse, including sex doesn't equal gender and reproductive exploiter. Just a few months later, In August 2021, one of Madrid's LGBT bookstores, Mary Reed, was also vandalized with anti-trans graffiti. The storefront spray painted with sayings like sex orientation is existence and no to the hormonation of underage children and saying the truth is not a crime tainted this queer and trans affirming space. In the same month, across the Atlantic in Ottawa, Canada, trans affirmative posters were put up across the city by the Ottawa Coalition to End Violence Against Women. The posters were vandalized in various ways with anti-trans messaging and met with a counter campaign of trans exclusionary stickers, some of which read, "Woman is not a costume," "Gender is not another word for sex," and "Gender is fleeting, sex is forever." Months earlier, in February 2021, just south of the Canadian border, Marjorie Taylor Greene, an American far-right politician who serves in the US House of Representatives, posted this anti-trans sign outside of her office door. It reads, "There are two genders, male and female, trust the science." Across the hall from Greene was the office of Marie Newman, a state representative from Illinois whose daughter is transgender. So these discrete anti-trans gestures around the world can be read as a response to legislative efforts that seek to affirm trans people. For instance, in June of 2021, after months of pushing for its acceptance, the Spanish government approved a draft of a gender recognition bill allowing anyone over the age of 14 to change their gender legally, as it is marked on an issued identification, so like ID cards, without a medical diagnosis or hormone therapy. So you can just like elect to change the gender marker on your ID if you're 14 or over. In 2023, a different version of the bill became law. So it passed as law in Spain, increasing the age from 14 to 16. So the original bill didn't pass, but it increased the age at 16, it then did pass. At the time of Greene's antagonistic poster hanging, the Equality Act, which would amend the Title VII of the U.S. Civil Rights Act of 1964 to ban discrimination on the basis of a person's self-determined gender identity, this was under review. Greene was attempting to block the Equality Act, this amendment to it, claiming that it destroys women's rights. Although the bill passed the U.S. House of Representatives, it failed to move through the U.S. Senate. These forms of legislation are not necessarily a boon for transgender people. So like trans affirming legislation is not necessarily going to liberate or make better in certain ways the conditions in which trans people live. Trans scholars like Dean Spade have made clear that legal recognition of trans people can be understood as another way for states to administer, that is, regulate individual experience and collective arrangements of gender. In other words, getting the state to see you for who you are, or who you really are, isn't necessarily liberatory. It's a means of being governed. So that's Spade's argument. Regardless, though, it's clear that these legislative moves to recognize trans existence instigate ire and antagonism on the streets and out in the world. The numerous instances of anti-trans vandalism exemplify trans exclusionary political discourse that aims not only to delegitimize trans people, but also refuses rather forcefully efforts that seek to affirm the lives of trans people. So to understand the harm of this refusal, the refusal to affirm trans people, I think requires an address of the ethical significance of gender affirmation. So not as a political phenomenon, not as a legal phenomenon, but as an ethical one. In other words, we can best grasp what is wrong with the refusal to accept trans people on their terms when we know something about the significance of avowing trans experience. In mainstream discourse, gender affirmation usually means the acceptance or support of an individual's gender identity. That's what you see up here. So whether people are conscious of it or not, this conception of an affirmation of gender identity is most often rooted in psychological conceptions of gender identity. That is the idea that gender is an internal, sense an individual has of who they are as a gendered person. On the gender identity model, gender is held in distinction from biological sex, which need not, but often does bear correspondence. And affirming gender identity is a matter of affirming an individual's inner felt sense of gender, not holding an individual to that direct correspondence between biological sex and gender identity. So like the mainstream model of gender affirmation is rooted in gender identity theory, which I'll talk more about in a moment. Such that what we're doing when we're affirming someone's gender based on this model is we're affirming their inner sense of who they are, not demanding that it correspond to biological sex. So the psychological model is at the heart of most popular discourse of gender affirmation, gender affirming care, which serves as the basis for legislative efforts to secure the legal recognition of self-defined gender. In many ways, this model of gender affirmation rooted in gender affirming care has proven productive. It's been a formal gateway for gender transition. Once authorities on physical and mental health began to vocalize support for gender transitions, the contours of and access to care changed in ways that gave some people, some trans people, increased access. That formal gateway and the authority of doctors in particular has legitimized, no doubt, some trans needs, bodies, and desires, which in turn has bolstered, meaning supported, further affirmative legislative movement. Yet, so here's a critique I'm going to offer. This model of affirmation rooted in gender identity and the psychological model of gender identity has limits. Most importantly, as I'm going to talk about, gender identity discourse is not a godsend for liberatory experiences of gender. Indeed, so my view is that gender identity discourse reifies, meaning it reentrenches dominant beliefs about gender and ways of knowing and practicing gender. The result is that the psychological or medical model of gender affirmation winds up securing an authoritative conception of gender, even if it also confers recognition to some trans people. So it's kind of doing this one limited thing that seems good, and I'm arguing that what it's actually doing is something that's more pernicious and that we should be concerned about. The result then is a contradictory practice of gender affirmation. Some trans people, usually the most affluent, white trans people, gain recognition, but that recognition entrenches a dominant pedagogy and practice of gender. So I'll talk a little bit about what I mean by pedagogy of gender in a moment. So what I'm going to offer is an alternative way to conceive of gender affirmation, one that's not rooted in the psychological theory about gender, but in an ethics. So to be more specific, I'm arguing that we need a conception of gender affirmation that is rooted in how we ought to relate to one another. So trying to move from a conception of identity to a conception of relationality, which is also going to entail, but I'm not going to talk about, a different way of understanding what gender is in itself. So while people may currently speak about gender affirmation as a matter of authorizing someone's gender identity, such a view doesn't actually get at what the world genuinely get at a world that genuinely affirms trans people. That world requires a particular kind of relationality. An ethics of gender affirmation helps account for why even those of us who are critical of gender identity discourse nonetheless affirm trans people's self-defined genders full stop, and why everyone else ought to do the same. So that's kind of my ethical argument, is that we all ought to affirm trans people's self-defined gender full stop, without question, without suspicion, without scrutiny. But I want to suggest that we not rely on gender identity discourse to do so. So I'm going to kind of say a bit more about the mainstream notion of affirmation and gender affirmation in this sense, as it is mobilized politically, and that is really around gender affirming care. So gender affirming care designates a wide range of social, psychological, and medical interventions that support an individual's gender identity. when it is incongruent with their gender or sex designated at birth. It's a model of care that rests on standards established by the World Professional Association for Transgender Health, also known as WPATH, which was founded in 1979. WPATH is an organization of social, physical, and mental health professionals and is the longest standing recognized collective authority for evidence-based care for trans people. WPATH was originally named the Harry Benjamin International Gender Dysphoria Association, or the cumbersome HBIGDA, after Harry Benjamin, a German-American physician known for developing early practices of professional medical interventions for transsexual people. For Benjamin, such interventions were medically necessary on the basis that the dominant psychological approach to treating people with, quote, gender identity disorder did not cure the disorder itself. So according to Benjamin, what was needed was not just a psychological intervention. What were needed were medical standards that allowed people to change their sex so as to, quote, fit or, quote, align their body with their mind. This was Benjamin's conception of what was going on with his patients that he was seeing. With a nominal transition of its own, that means a name change of its own in 2007, HBIGDA became WPATH. And in a sense, because Harry Benjamin's clinical practices were taken to be problematic, WPATH is trying to, in some ways, dissociate from that kind of that work of Benjamin's. In 2011, HBIGDA is now WPATH, and it issued its 7th iteration of the standards of care. This version, the 7th version of standards of care, sought to finally address decades of criticism from trans people about WPATH's model, that it relied on medical gatekeeping and the pathologization of trans experience. So it wasn't until 2011 that WPATH thought to really consider trans people's experiences and critiques in its revisions of standards of care. So rather than treating trans experience as an illness, the 2011 standards of care moved toward an affirmative model. In a statement released just prior to the new standards of care, WPATH declared, this is a quote, "The expression of gender characteristics, including identities, that are not stereotypically associated with one's assigned sex at birth is a common and culturally diverse human phenomena that should not be judged as inherently pathological or negative." So WPATH's work has been one of the main architects and proponents of increasing access to gender affirming care across the world. The adoption of WPATH standards by medical practitioners has no doubt led to an increase in trans people of all ages accessing the established age-appropriate medical interventions, with puberty blockers, hormone replacement therapy, and certain surgeries as viable and medically validated options. The social landscape of sex and gender is also undergoing a transition. We are not just stuck with the bodies we have. Of course, such a reality isn't new. Non-trans women have long accessed breast augmentation surgery to affirm their womanhood. Non-trans men have long doped themselves up with testosterone, indulged in Viagra to secure their gender, to affirm their manhood. What is different, however, with gender affirming care is that it does not fully support the dominant ideology about the meaning of our bodies, that you can change sex. So it's no wonder then that a significant portion of anti-trans legislation and policy works to eliminate access to gender affirming care. So here you see some of the responses to that anti-trans legislation. Most legislation targets the possibilities of trans childhoods, insisting that gender affirming care for minors is fraught with danger. Regardless of what medical professionals say, legislation that goes after gender affirming care, legislation that is written by politicians and their supporters, insists that medical care that allows children to become trans or be the trans kids that they are is problematic. For instance, in the United States in 2023, almost half of the state legislatures had advanced bills to end gender affirming care, especially for minors. In the state of Texas, gender affirming care for minors has been framed as child abuse, while other states have taken a quote, more moderate view, deeming it medically unsound. As of late 2023, so right now, 5 American states consider it a felony to provide gender affirming care to minors, while 14 others have passed various sanctions and restrictions on it. All the while, the American Medical Association stands in opposition to this anti-trans legislation. Equally concerning, across the pond or across the Atlantic, the National Health Service in England ended its reliance on gender affirming care model for minors, the one supported by WPATH, moving away from WPATH standards and promoting a view instead that minors need only psychoeducation and psychotherapy to kind of fix their experience. These new NHS guidelines in England also strongly discourage socially affirmative transition practices for minors, such as those of chosen names and pronouns. So they're not just saying we shouldn't allow medical care to happen. There's also saying we should also limit social transition as well. These political efforts to, quote, save and protect children, that's often the discourse in which they fall under, are not innocent nor necessarily benevolent. As writings about moral panic show, such efforts are always also a matter of shoring up dominant ideologies and relations of power. They're not necessarily ever about genuine care for children. So in response to the emergent legislative zeitgeist against gender affirming care in the United States, as well as other parts of the world, WPATH released a statement of opposition in March 8th of this year, so just a few months ago. In it, WPATH's president, Dr. Marcy Bowers, this is the first quote you'll see up here, insists anti-transgender healthcare is not about protections for children, but about eliminating transgender persons on a micro and macro scale. Echoing that gender affirming care is a matter of life and death, that is, that it saves lives. Dr. Maddie Deutsch, who is the president of USPATH, the United States affiliate of WPATH, argues that, and this is the second quote, medical professionals and experts who research and practice in this field must be able to do their jobs in providing life-saving care for their patients without legislative intervention. So ultimately, far from harming trans people and trans kids in particular, the sentiment is that gender affirming care saves lives. So that's WPATH's position. That's also the position of those who resist anti-trans legislation, is that gender affirming care saves lives. And not gonna deny that gender affirming care saves lives, but I want to complicate the reliance on what's underlying gender affirming care. So trans scholars and advocates, as well as some trans people more generally, have voiced criticism about WPATH for its gatekeeping and, until more recently, its pathologization of trans experience. So neither of those are unique to WPATH. That is like the gatekeeping and pathologizing of trans experience, but they have a lot of force with WPATH because of the authority WPATH has to dictate what it is that trans people can experience and have access to. So gatekeeping transition, whether that be social, we're referring to name and pronoun changes or changes in ID markers, or medical, by medical and psychiatric doctors, is a salient feature of trans experience. So something that's really common to the possibility of being who you are in the world. Although some doctors may be willing to allow for gender affirming care, it is not up to a trans person whether they can receive such care. Rather, the gender affirming care model rests on a model of authority in which the doctor is positioned as the final arbiter over trans possibilities. So contrast this reality to procedures like breast augmentation for non-trans women, which are taken by the Western medical world to be elective and not pathological. Even as the standards of care set forth by WPATH move in directions that minimize transness as pathological, the power of doctors to authorize care still remains. Bringing trans experience in proximity to the medical establishment does not finally allow people to be trans, they already are. Rather, this proximity opens up a complicated web of agency and constraint, possibility and limitation, access and restriction. So I'll talk about these two thinkers really shortly. So underlying the standards of care, in turn, the reality of medical gatekeeping is the history of gender identity theory. So go back to Harry Benjamin. Often targeted by gender critical feminists, sometimes called TERFs, as not only erroneous, that is gender identity theory, but in the words of Kathleen Stock, who is a well-known gender critical feminist, gender identity theory is, quote, intellectually confused and concretely harmful. So we might be shocked to know that trans scholars also have serious critiques of and concerned about gender identity theory. So here's two examples of trans scholars who also critique gender identity theory. The concept of gender and subsequent iterations of it as gender role and gender identity was a medical intervention largely established by psychologist John Money and then leveraged by Money and his colleague Robert Stoller in their work on intersex children and later trans patients at Johns Hopkins University throughout the 1940s, 1950s, and 1960s. And Jules Gill Peterson writes about this history really richly in her book, Histories of the Transgender Child. For Money, gender indicated a dimension of embodiment distinct from biological sex, commonly viewed to be both a simplistic biological category and as determinative of who you are. Money found himself in the midst of research and human experience that suggested otherwise. As Jules Gill Peterson explains in Histories of a Transgender Child, Money was at the heart of what she calls an epistemological crisis over the category of sex, meaning how we know what sex is, what do we know about it. It had become, according to Gill Peterson, an unwieldy biological category composed of various features, none of which, and this is a quote from her, exerted what amounted to a deterministic influence. So if sex didn't determine who we are, how ought we understand it? What can we understand about what sex is anyway? Money's intervention in that crisis was to fashion a new category that could keep the dominant binary view of sex embodiment intact. In his research on intersex children, Money proposed that gender roles were learned and could therefore stabilize, quote, ambiguous and indeterminate sex. Money established a protocol to assign gender to intersex children for the sake of, quote, normal social development. In the 1950s, Money undertook research with psychologists Joan and John Hampson that ultimately insisted on the necessity of medical intervention to align sex with gender. They argued that, and this is a quote from Gill Peterson's work, a gender role that contradicted the visible body could be identified as pathological because it might lead to social stigma or psychological distress. That position became the justification for normalizing and coercive interventions into intersex children's bodies. It also became the foundation of American trans medicine. The medical insistence that the visible body should align with gender sanctioned medical interventions for trans embodiment, meaning it made them possible. Sex reassignment was cast as the completion of, quote, normal development and framed any incongruence between one's body and one's sense of self as pathological. Far from a purely liberatory medical technology, that medical intervention, the medical invention of gender and the gender identity theory was actually a normalizing device. It was not rooted in trans affirmation. Or as Gill Peterson puts it, the concept of gender, as developed by Money, greatly reinforced the binary coherence of sex and established a vicious clinical force that disqualified less medicalized or non-medicalized forms of trans and intersex life, right? So like Money is the one who invented this concept of gender and then invented the way in which the treatment for trans medicine then persisted. So that there's a history to gender affirming care that we should be thinking about in more complex ways. This is ultimately what Gill Peterson is pointing out. So in the context of contemporary gender affirming care, gender identity theory is central to access to and approval of care. In order to receive care, a trans person's experience must fit the demands of the medically established discourse. In a critical analysis of his pursuit of top surgery, trans legal scholar Dean Spade described how his experience was governed by the psychological conception of gender identity and the related diagnosis and, quote, treatment of gender identity disorder. Spade describes how his access to gender affirming care was dependent on whether his experience fit the expectations and assumptions of the medical model, especially that of what he calls the transsexual childhood narrative. Spade, in the face of counselors who he has to talk to get approval for top surgery, is regularly asked to speak to, quote, when he first knew. That is, to describe his gender identity as emergent in childhood. Having a childhood narrative has long been a necessary condition for accessing gender affirming medical care. That is, a trans person must have a childhood narrative or else they will be denied care. Meaning you have to say, I've always known, I've always felt this way, or I first knew that I was trans when I was 4, when I was 3, I felt this way. So Spade says this is a requisite. You have to speak in these terms. It is expected. If you don't, there's going to be barriers to receiving care, if not full denial. From the medical perspective, the childhood indication of internal gender identity speaks to a transgression that must be corrected, not for the patient's autonomy, but to end their pathology and allow them to live a, quote, normal life. Spade puts it this way. This is a quote from an essay in the transgender study reader called Mutilating Gender that Spade wrote. In order to get authorization for bodily alteration, this childhood must be produced and the gender identity disorder diagnosis accepted, maintaining an idea of 2 discrete gender categories that normally contain everyone, but occasionally are wrongly assigned, requiring correction to establish the norm. So the transsexual childhood narrative, although seemingly objective because it comes from medicine, and seemingly affirmative because it affords access to some care, enforces a certain reality of trans experience, one that relies on the conception of gender established by money and his colleagues. The expectation is that all people have a gender identity, which is an acute reality for trans people who cannot live theirs out. Although the basis for gender affirming care and therefore although it's a basis for gender affirming care and therefore it seems to be unproblematic, the theory of gender identity trans people are required to speak in terms of, regardless of whether that's actually their personal experience. So Spade is like very clear. This isn't my experience at all, but I have to speak in these terms in order to access this care, right? So that the theory becomes a totalizing discourse that then shapes narrative about what transness is. So some of us, for instance, do not have a childhood narrative, but nevertheless do not experience ourselves in accordance with a birth assignment. Some of us do have a childhood narrative, but don't experience it as dysphoric or as a maladjustment to be corrected. Some of us don't want to be normal, but desire certain medical interventions. In other words, from a critical trans perspective, the theory of gender identity is productive, meaning it creates a reality in which we all have a gender identity. Although it may seem all well and good if it creates access to care, it's nevertheless authoritative and normalizing. There is a demand to speak in its terms. It is therefore not an objective reality to be discovered about each of us or that we're like expressing some inner truth. It is produced. The expectations and assumptions of the theory of gender identity does not just frame access to medical care. It infiltrates our everyday social practices, even ones that aim to be trans affirming. It's often the case that non-trans people expect that being trans is a condition that begins in childhood. If it does begin in childhood, the assumption that it is something to be treated. There's also the assumption that someone's experience of gender is a matter of internal identity, such that affirmation is an affirmation of someone's essence. When, for instance, asking for pronouns, my wager is that most people think they're finding out some inner truth about a person. That, I think, is the naturalization of gender identity theory in our everyday lives. So I'm obviously offering a critique of gender identity and gender identity theory as it's kind of like infiltrating our social, political landscape. And that's a delicate critique to offer, insofar as meeting conditions of gender affirming care does provide some trans people a pathway to embodying who they are, and meeting their desires. But this model of affirmation is also deeply fraught. It raises important questions about how transition-related care should be handled and who should have the authority to regulate access, or if transition-related care should be available at all. These are certainly issues central to anti-trans efforts. While they are undeniably important ones, especially as gender-affirming care does save lives, so I'm going to be very clear, that's a position that I take, and especially as mainstream access to trans healthcare is being undermined right now, those issues, the focus on who should regulate it, who should have authority, also obscure another set of questions, one that I'm more interested in. What is gender affirmation anyway? Is it really a matter of acknowledging a gender identity, of an inner gender identity? Although seemingly more abstract, how and whether these questions are engaged is a matter of how we understand what it is to live together in ways that are not simply stuck in a cycle of reaction and response to trans antagonism, but that conceive of another way of being in relation altogether. All right, so now I'm just going to shift to this other model of gender affirmation, rather briefly, but I'll be happy to talk about it more in Q&A. So there's a conception of, I think in the United States, there's lots of discourse around a self-determination as this like liberal notion of being free to choose and choose who we are. In the context of trans literature and trans context, self-determination has a very specific contour and a very specific meaning, really just related to giving priority to self-definition over gender. So it's kind of limited in this capacity. So a philosopher, Talia Becher, gives us a way to kind of understand trans self-determination as a particular ethics by telling us something about our dominant practice of gender rooted in what she calls third-person authority. Third-person authority over gender normalizes and naturalizes a non-consensual conferral of gender by others. So we're just used to being assigned a gender and others telling us who we are as a gendered person. And we take that to be like a natural phenomena. You have this biological sex, therefore you're that gender. It seems obvious. But you're saying this is a social practice. This is a particular way we have of relating to one another in relationship to gender, that the dominant social practice is others get to tell us who we are. You can contrast that practice to what Becher calls trans first-person authority. So it's not first-person authority in general, it's a specific phenomena of first-person authority, trans first-person authority, which is that an individual is the one who decides who they are as a gendered person. So Becher is going to argue that in general, FPA, first-person authority, raises lots of questions. We can be deceived about what we feel. We can be tricked by our feelings to think something is really one way when it's the other. And that's what we would call an epistemological issue. That first-person authority raises epistemological issues about who knows best. And Becher is going to say that that's actually not what's at stake when it comes to first-person authority. He's going to argue that what's actually at stake is an ethical issue. So for Becher, third-person authority really tells us about a specific kind of transphobia, which she calls the basic denial of authenticity. And that this basic form of transphobia is rooted in third-person authority over gender, that I do know better than you about who you are as a gendered person. And that it can be intentionally malicious, like I'm just going to intentionally misgender you, or it could just be unintentional, that based on your gender presentation or my perceptions of your gender presentation, I assume you are this kind of gendered person. For Becher, this is all rooted in the assumptions that gender presentation paradoxically communicates our genitalia to others, and that third-person authority is rooted in genital status. So not conforming to this expectation that I perceive you to be this way, I assign you this gender, therefore this is who you are, results in the denial of trans first person authority and subjects trans people to scrutiny. So whether that scrutiny is like, I'm suspicious of who you say you are, I don't think you are who you say you are, or it might result in physical violence. So ultimately, the most basic form of transphobia for Betcher is just rooted in third person authority over gender, where we get to assign and give gender to other people rather than creating space for trans first person authority. So I want to kind of suggest that third person authority over gender is a certain kind of pedagogy of gender that we all come to learn, and we learn it in ways that are both conscious and unconscious, but we learn it. That's the pedagogy of it. And we practice it all of the time with one another. Again, consciously and unconsciously, often not maliciously, but that it is actually rooted in a certain kind of relationality in which it is about power over others. Right? And that's actually what we're reproducing when we give gender to others, when we assign or confer gender to others. And that makes the reality of self-defined gender nonsensical, pathological, right? It's actually a practice, an instruction, a lesson in gender that makes first person authority appear in the world as if it is a pathology, as if it is nonsensical. Betcher wants to say that trans FPA isn't an epistemic issue, it's an ethical issue. And it's not about what you are, it's about who you are. But the denial of trans first person authority is a refusal of not what a person is, but who a person is. And this shift from what to who, from the epistemic to the ethical, is really about how we relate to ourselves and relate to other people, and what kind of world we ought to create in terms of relationality. So the relational structure of trans FPA is different. And it's this distinct structure that I want to suggest is what makes gender affirmation ethically significant. It's not about affirming an inner gender identity. It's a matter of how we get to relate to one another. So what trans FPA does is that it's not about giving priority to others to tell me who I am. It prioritizes the sense an individual has of who they are, regardless of why they have that sense. We don't need to know that, Betcher argues. What we need to prioritize is just this capacity to be in relation to one another in different ways. So it's a paradigm shift from power over to self-determination, right? And to trans self-determination in particular. So yes, it's not this like kind of liberal, neoliberal conception of self-determination. It's really rooted in a trans practice. So this trans conception of self-determination isn't individualistic though. And this is what I think is key. It's a relational self-determination, which seems like a paradox. It is about me getting to tell you who I am, but it requires that you also listen and engage who I am. It is a matter of being in relation. It's a condition to be in relation. So this paradigm shift from power over to trans self-determination is what I'm suggesting where gender affirmation should be rooted. So in this sense, an ethics of gender affirmation is really about how we get to make meaning with other people, how we get to make gendered sense of ourselves, with ourselves and with other people. And it relies on an openness in communication and meaning. And so I'm going to suggest that gender affirmation conceptions that are rooted in the gender identity model are not rooted in this structure of relationality. They're actually still rooted in relationality of power over others. And we see that in the sense that it is doctors who get to authorize your gendered sense of self. You may still have your gendered sense of self, but it's still not up to you. It's still up to others to say, yes, okay, you can be this person in the world. Whereas trans FPA is insisting that we start to have a different kind of structure of relating and a different structure of meaning. So ultimately at stake in trans FPA is not only an individual's ethical avowal of who they are, meaning like, I'm saying this is who I am, I'm taking responsibility for who I am in the world and how I want to be perceived, but it's also a restructuring of social interactions and how we make meaning together, how we inhabit the world together. That's what I want to suggest we ought to focus on. So just to kind of conclude, the ultimate point is that while gender affirming care does save lives, I want to suggest that it offers a really limited conception of gender affirmation that is still rooted in a model of power over, in which gender is determined by authority. And that actually doesn't get us to a different kind of world. I want to say a world that is one we ought to live in. What we need is a different relational practice of gender. I want to say that we can find that relational practice when we pay attention to trans pedagogies of gender, particularly trans self-determination, which is related to trans first-person authority. And that is where I will stop.
We have a couple of minutes for questions.
Yeah, for me.
Hey, Dr. Burke.
Hey.
Thank you for the presentation. How do you reconcile transgender affirmation when it comes to labels in that process, right? So trans folks that still are going through this process of affirming the male identity or the female identity, those labels, is that an issue? And how do we move past those labels that confine folks?
Yeah.
If that makes sense, yeah.
Yeah, great question. I mean, I think if we lived in a world where we had openness in meaning and communication, that issue of confinement would become would start to move in different ways. Right. So I think the idea that labels are confining and categorizing is rooted in this world. And so if we start to move have a kind of paradigm shift, I don't think categories necessarily need to be confining and constraining, right? So that it might mean that we can move more freely between categories, or that our sense of self as inhabiting a category doesn't necessarily need to be constraining for ourselves or others. And I think that relies on a shift away from third-person authority over gender. I see third-person authority over gender as what constricts categories itself. I'm not necessarily sure categories themselves have to be confining, though for some of us they might be, but I don't think in themselves they have to be confining for everyone. Categories become confining when other people put them on us and when other people put their expectations of those categories on us. And so I think that the paradigm shift of between a pedagogy from third-person authority to one of first-person authority can also undermine that experience of the problem with categories. Yeah.
If we live in a world where this is normal or is socially acceptable, how do you think we should present that to children since they are so vulnerable?
Yeah, I mean, I think that children are really creative, and I think we just drill that out of them. Actually, I don't actually think that there's a problem with creating openness in gender play and possibility for children. I think that's a concern that is rooted in the state of affairs that exists around gender. So I don't actually see like a worry about presenting lots of possibilities to children. I think that's a concern that people have that is rooted in, whether they want to admit it or not, in a certain model of gender that's trying to maintain a certain world.
Thank you.
Yeah.
So with the medicalization of transness, there's sort of this, as you said, the third person authoritative standpoint on gender. But in this first person self-determinative standpoint, how does medicalization work? Because I mean, as I understand it, medicalization as a whole for everything is kind of third person authoritative.
Yeah, it's a great question. So the part of the chapter you can't hear because of time is actually on the panic over detransition. right? That, you know, if we allow people to transition, what about the very few small numbers of people who regret their transitions? Which, you know, they often name themselves as detransitioners, right? Doesn't that tell us that we need to have medical authority involved in transition related care processes, right? And that we should re-entrench authority. And my suggestion is that we have to become better at embracing ambiguity and unknowns and uncertainty. And also that I'm not saying that doctors shouldn't be involved. I'm just suggesting that the idea of authority over is one that we can also undermine with different kinds of practices of communication and relationality, such that that can also be a part of medical care that hasn't historically been a part of medical care. Right, and so that might mean richer dialogues about what it would look like to actually give trans people agency, right, in ways that have been historically denied in relationship to doctors. And yeah, I'm not saying that that's an easy conversation to have, but I think that that's one that is possible, but not necessarily imaginable, given how medical care has been historically undertaken in relationship to trans people. So I think there's more room for self-determination is ultimately to say in relation to medical care. And it's also the case that, as many trans thinkers will argue, that, you know, a formal medical care isn't necessarily going to be the place where trans people experience liberation, that there are other trans practices of transition that historically predated you know, the formalization of medical transition, and that those might also be better avenues for trans embodiment.
Okay, so we have hit our hour, and if you have any more questions, please talk with Dr. Burke. We'll be out in the lobby here, and let's give her a minute.